Good morning, everyone. Welcome. Thank you for joining us for today's Infection Prevention and Control Q&A breakfast session. So hopefully you are having some breakfast, making the most of this time before you start your busy days. So I'm Charles Broadfoot. I'm one of the Professional Development Officers with Hunter New England Central Coast PHN. And I would firstly like to acknowledge the First Peoples and traditional custodians of all the lands in which we are meeting on this morning and pay my respects to elders past, present, and those who are emerging. Today's session is being recorded, and this recording will become available in our PHN Education Library on our website a bit later today. There will be a very short evaluation survey that'll pop up automatically when the webinar ends. If you could just take a moment to fill that one out before you log off, we always appreciate any feedback you can give us on our education events. So this is a Q&A session, so we're definitely encouraging you to type in your questions this morning. So you'll see a questions pane in your control panel. Please type them in from now throughout the session, and I'll endeavour to get all of these over to Marg, and I'll read these out for you. So it's now my pleasure to introduce our expert speaker and friend of the PHN, Margaret Jennings. Marg is a microbiologist and infection prevention and control educator. So welcome, Marg. Thank you for being here with us. Now, whilst we are waiting for those first few questions to come in, I know we were just chatting about some of the key issues that you're seeing at the moment, and thought maybe we could introduce with a bit of information before we get into the Q&A.
Okay, thanks, Charles, and good morning, everybody, and pay my respects to your country. And I'm speaking from cold country, Wurundjeri country, so thanks for inviting me. I was actually, for some ridiculous reason, awake to listen to a repeat of the health report this morning. Don't even ask why. Probably because the alarm was set to, be up here for you guys. And you would have heard, it's a really good little listen. I think it was about 5 o'clock or 5:30. But having said that, I did have a few issues in mind to provoke some questioning. And the first one is around everybody's quoting the Doherty model. Now, I have to tell you, I am not an epidemiologist, and I'm very interested in how many people are currently. Some of them are politicians. So what I really want to say is the Doherty model is specific. If you listen to the people who wrote it, some of the interviewers will try and pin them down and say, so do you mean this? I think what is quoted from the Doherty model, which you've really got to sort of think about, is that the projections were pretty much taken on, it was done some time back. It was really done on just a few cases a day. If you say to me, Marg, we had 820 people, etc. yesterday in New South Wales, I can tell you haven't got 820, you've got more. You've got 820 that you found. So we need to kind of think about the reality. So the reality is I've got far more than 820. They're just the people who turned up 2 days ago for a test. Yesterday I've got more, and today I've got more. And I've got more because this thing is growing exponentially, because we don't have enough people for it to hit who are protected and stop it from spreading. It's looking, I've got my special model. I always lose my special virus when I need to show it. Here it is. It's looking for your throat. It's going to find it. One mask between two people, one wearing it, one not enough. Two people wearing surgical masks, one's got COVID and they're close up. Two surgical masks, not enough. So this thing, we do not need as many bugs. We do not need as long together to get this thing. This is the Delta strain. So, it's up the stakes. I'm also listening to that report this morning, the health report. They interviewed the guy from the Burnett. I actually follow the Burnett Institute stuff. It's not in competition with Doherty, don't get me wrong. They're both asked to provide figures. But what he said that sort of, made me wake up a bit was that he said, although you might think regional New South Wales and currently has less numbers, it's actually moving, increasing at a more rapid rate than Sydney. And that there'll be an intersection in about 4 to 5 weeks of the same numbers. I think that's really instructive. So keep listening, keep practicing all the measures, and I can tell you, word came to me yesterday of a clinic in an area that's currently having an outbreak in Victoria, and the clinic actually asked the PHN, so when we are swabbing our patients, like inside, if one of those patients is positive, do we have to close down? My heart sank. This is a clinic obviously not listening to us, to me. We don't swab patients inside. Who wants to close down or be a risk to others? And can I just say, in this same place, in Victoria, some people had symptoms for 5-6 days. Oh, it couldn't be us. There are no cases in regional Victoria. Don't be like that. Okay, they've now uncovered 40 or 50 more cases in this area, and this is leading to a substantial outbreak. And I'm thinking of regional New South Wales as I say this. You know, we all think, oh, it couldn't be us. And even those poor 820 people who were positive, you know, the results came through yesterday, ask them before they took the test, do you think this result will be positive? Human beings are notorious for assessing self-risk or self-assessing as low. We're brilliant at it. That's why the pandemic gets going. Why should I stay home? I'm okay. So, you know, this is the stuff that goes over and over. So I wanted to say, be very careful about who. I want to get my facts from, Norman Swan introduces me to people who give me facts. He doesn't just make stuff up. He's my journalist, if you like. So if I'm listening to him, I want to know what his source is, but I actually like to listen to the source. I like it when he interviews people. I take more notice of them than I do of him, to tell you the truth, because I do want that source. And I'm also understanding this is a dynamic situation. So if I look at the fact that people are saying, oh, but you know, the immunisation hasn't been around long enough, I'm not sure. I just have to grab, no, I don't touch them at all, but I just have to say to people, yeah, this is real time, evolving. These are the results right now here in front of you. You would have heard that the Pfizer has given formal approval overnight by the FDA. Now, some people are a bit shocked. They say, well didn't it get it got emergency approval because the initial results showed it was doing well. And in fact, the fuller results are showing that, in fact, the AZ vaccine was really pulling away in terms of, antibody response from the Pfizer. But after 5 months, they're both about the same. So, you know, the AZ is a really good vaccine. For those who are sort of AZ hesitant, I mean, we need to be telling them that when you go for a vaccine now, you're absolutely grilled about how to look for, you know, what particular symptoms. I'm thinking of that's horrible clot. And secondly, the doctors are upskilled on this. So, you know, I think that's why we're a lot happier about the younger group coming in and getting the AZ. So I did want to mention, when people quote the Doherty figures, I just honestly go a bit like that. I want to hear what the Doherty people have got to say, because they can put their finger on some of those figures. So I would be a little bit shocked if people were running around New South Wales saying we can open at 70% immunisation. No. That gives me 56% total population immunised. No. I'm going to get loads and loads and loads of cases. So I present this as, imagine a vertical wall of 100 people and half of them are immunised, 56% are immunised. And behind them stand 3 or 4 people, and half of them are immunised. So coming towards this vertical wall of people is a big cloud of SARS-CoV-2. So you can immediately see the 56 who have some protection generally won't get this. Yes, we do know that the odd person who's immunised can become infected and pass it on, but, you know, it's a model. But you can see there's holes in that wall of people who are going to get it. Not everybody will get it. Just because you're not immune doesn't say you will automatically get it. There's other little factors there. But we do know that this is a highly infectious organism. We just don't seem to need as many viruses to get sick, which is a problem because it means less contact will result in infection. But behind that wall of the 44 who are exposed is a wall of 3 or 4 people, and half of them are immunised. So can you see that immunisation, even at I'll grant them 70%, will offer some protection. It's just way not enough. You can't ever call it herd immunity. So please don't talk about 70% as herd immunity. And look, my other concern, which leads into this next issue, is about children. And those who are involved in the paediatric field would of course know about the more serious complications from COVID. And I know that there is a push, that will probably go 12 to 16 very shortly, but there's also a push to have 5 to 15 done. And what is holding that up can be a number of issues. So only going back to first principles, the dose we give children versus adults can differ. The reaction for children can differ. If it were a disease that children just almost showed no symptoms from, fine, but this is not the case. 2% of children are being hospitalised. And I mean, there are some people who think that's nothing. You think about your street, you think about your suburb, 2% of kids hospitalised. That's significant. Now that's how sick those kids are. And I know in Melbourne, we've got a little infant in the Royal Children's at present with COVID, and a number of kids under 10, and I know it'll be much worse in New South Wales. So I don't want my 4 grandchildren getting this. We also know kids have got a great capacity, especially around that 9, 10, 12, 15 age. Ability to produce an immune response is just, par excellence, can't be exceeded. They're the ones we should be putting in the front line, I'm telling you. So thinking about children, that's a real concern for me. It's a personal concern as well as a community concern. I'm surrounded by kids in my street, and these kids are in their homes and allowed out for an hour each day. And I don't think the rest of us who say, I just want freedom, what will happen is a massive infection among children. And so if you think, isn't it a shame the schools are closed now? Believe you me, if you get this running through a school of unprotected kids, the school's going to be closed anyway because the kids will be sick. And so we know that herd immunity's got to be about 85% protection. So if you've got a vaccine that's about 90% effective, you'd be looking at maybe 85% if you just don't want it spreading. So that brings us to this issue about we have to learn to live with it. Well, that's true in some sense, but at what level? If it's affecting the way society runs, then it's much better that everybody is in fact protected and that a breakthrough infection doesn't actually cause an outbreak. So that would be what I would want to get to, where it's just an occasional thing. But if you have a look at some of the modelling, you'll see that you'll still be in lockdown 30% of the time with a particular percentage of immunisation. I mean, who can even bear to think about it? So I wouldn't be getting into arguments about getting down to 0 or elimination or suppression. I'd be saying, what is actually happening? If this thing does get a leg up in my butcher's shop or, my supermarket, what would restrictive measures look like? And that might be, you've been to that place, so lie low. You and your family lie low for a week, or are you all protected? So being protected through immunisation, but not everybody immunised is a big issue. The worst time to immunise people and expect a big bounce from your vaccine is during an outbreak. This is what we're doing now, but we have no option. We have no option because this is our situation. So I would expect as I said, the figures in New South regional and city to start to cross over and reach the same level, because regional New South Wales is doubling every 10 days and Sydney every 13. they're going to cross at about 4 to 5 weeks. And I really don't know what's going to happen in Victoria. They're going for a suppression strategy, but we'll just see, because we're pretty much under the pump. We've got curfew, etc., and just minimal, minimal mixing at all. But the virus, just looking for your throat. Now, Charles, any questions? Hopefully that's provoked a bit of, hopefully not anxiety.
No, that was really, insightful. Thanks, Mark. We have had a couple of questions. The first one from Leanne. With testing and patients getting a negative result, should doctors be waiting longer than 1 to 2 days before seeing these patients? Should these patients be advised to stay home for 5 to 7 days, as we are finding that they may still develop symptoms after a negative test?
Oh, yes. Yeah. So first of all, I don't know whether people understand Tier 1 and Tier 2 exposure sites. And this came, I was with an Aboriginal organisation yesterday and explaining what it is. So Tier 1 is where the person who is the case has really, spent some time, fiddled around with stuff, had lots of touch contact, been coughing, etc. And of course, in some parts, last week and the week before, it wasn't mandatory to wear masks in regional Victoria and possibly regional New South Wales. And so you can see that sort of spread is going to be on. So Tier 1 is where a Tier 1 exposure site is where the case has actually been. Tier 2 is just, I guess, a lower risk. However, the advice, and in other words, the person might have been through quickly and didn't touch much, or wasn't symptomatic at the time, was pre-symptomatic but a bit infectious. But the advice is quite different for the two, but it's pretty much taken on a case-by-case basis too. In other words, if you're the person in the shop and it's an inside shop and there's no air changing, even though that person was in front of you, for a minute or two, that may absolutely be enough. So whereas the person who came into the shop and browsed for 10 seconds and walked out, you can sort of see the risk is less. So always listen to the judgment after questioning by your public health unit, by your contact tracers. And actually, speaking of contact tracers, this control of the outbreak in New South Wales is very much about contact tracing, but you get to a point where contact tracing is simply overwhelmed. It simply cannot keep up with the number of cases, and that's where you begin to get further growth. And I just don't know how well it's holding in New South Wales. And that's the point, can I say, of locking down early. That's the main point. So contact tracing can get onto it. But, I'm not a politician, but that is the point. But it's a hard call because you've got those other things, people's mental health, etc. But I tell you what, nothing would sort people out or chasten them a bit more about hesitancy or scoffing than the first death of a child in hospital. And it's horrible to say that. But to see a little kid, on a ventilator or dying because of what it could be a preventable transmission, I think will be a bit of a game changer for us all. People will begin to look at it, I think, a little bit differently. So Leanne's question, just repeat that again, Charles.
Yeah, no worries. With testing and patients getting a negative result, should doctors be waiting longer than 1 to 2 days before seeing these patients? Should these patients?
Yes, sorry, yes. And? Yeah.
Yeah, let's answer the first one.
It's going to depend on the person's advice from their public health unit. So for some people, they're in that Tier 2 and the contacts are just advised to get a test at a certain point and then they're cleared and released. So you always wait until you're released by the public health unit. But other people have got to keep waiting because they've had close contact with the case, and even though they might test negative at 5 days, the contact, no, you've got to wait till day 13. I can't tell you how many people turned positive on day 13 at the Altaqua school in the north of Melbourne. you've got to do that 14-day quarantine, waiting to see if you develop it. But that was because they were close contacts. Tier 1 exposure site. Tier 2 exposure site, you may be released after one early negative. It's going to depend on the advice you give. So, you need to know what the exposure was and whether it was a tier 1 or a tier 2. Sounding complicated, but people are there to advise you, because, we've had people wandering around Melbourne who are close contacts, got a negative on day 2, I'm okay. No, go back to your sit, stay. You saw Sammy J. I hope everybody saw Sammy J on the weekend. This is about our poor dogs. I don't have a dog. It was about people saying their dogs are exhausted, being taken for walks morning, noon and night, and by different members of the family, and the dogs of Australia are exhausted. And all people need to do is take a note from the dog instructions, and it's sit and stay. So take the advice. If you've been advised to wait until you just have a negative test and you're fine, that's great. But others will be advised to wait a much longer time. But as I said, don't, if you're a tier 1 and you're a close contact, believe you me, the number of people who are getting positive on their day 13 test, I'm not saying they suddenly go positive on day 13, but I'm trying to think, is it day 3, day 6 and day 13? I can't remember, but there are 3 tests usually done. But it's that day 13 that they're coming in as big numbers of positive. Now imagine if that person's, I've had a negative test, I'm a close contact and I'm okay at day 3, I might go and see my doctor. I would have 50 fits. Seeing them outside, number 1. Okay.
So Leanne said thank you. Thanks, Mark.
Hopefully, Leanne, keep away from them. No, I don't mean that.
So we've got quite a long question from John. So what I think I might do with this one, John, is I might just send it to Mark after the webinar, because it's quite specific to a small ED, and there's a few questions around that. So if that's okay, Mark, I might just flick you an email with that.
Okay, can you give me a sense that would allow me to convey some principles?
Okay, so open plan ED using 1 bed bay for respiratory cases and 1 small room, non-ventilated, single room without an antechamber, and that opens onto a main corridor to a ward. Yeah. That's life, John. Now, John, I've got a couple of things that I'm going to send Charles the paper and he can send it on to you, but you may have, I'm sure everybody knew about the huge outbreak last year, that there was a lot of transmission occurred at our Royal Melbourne Hospital. And it was actually, I think, a ward. They brought in the people from this aged care facility where things weren't crash hot. And so they had a lot of, people with dementia, etc., yelling and shouting and whatever. And I think they'd opened up like an older part of the hospital, this older part. It was separate, let's say. But they got huge transmission to between patients, but also staff, huge. So you can imagine the number of staff who were furloughed. What happened, John, was that they said, we've got 4 to 6 air changes an hour. Like, what's going on? Now, this is last August. This is before we had our smarts. And our smarts were an understanding of airborne spread. So they switched over to P2 respirator masks, which you guys will automatically see in a high-risk area. You won't see a surgical, you'll see a P2, which will filter out a large number of respiratory particles containing the infection. They did that. They put people into single rooms as best they could. And they still thought, there's 4 to 6 air changes an hour. Like, what more can we do? So this began a lot more investigation about air. And what I can tell you, John, is that the hospitals now, and I'll send Charles the paper because I think it's interesting, is that this is the situation we're in, but what they installed were portable room air cleaners. Samsung, there are various models. They're about $800 each. And they were able to show testing, and they got the engineering at Melbourne Uni to do the testing.
and they were able to clear closed area. You've got to have closed room. And this is where I can't get negative pressure. And you know that lots of hospitals don't have negative pressure, rooms. So this is what they introduced, John. You can say yet to be tested, but they're using them now. And Kirsty Busing, Professor Busing, she was the one who wrote the paper, so I'll send that. But it was basically about installing these portable air cleaners, and you obviously needed 2 if it was a larger room, but they cycle through. It's a HEPA filter that the air goes through, and they spit out clean air. I think they've been used like for asthma and stuff like that in the past, but they showed that they did in fact hold back 99% of aerosols, which is not 100%, I know that, and it doesn't account for free virus, but most of the virus is held in the bits of spit and snot. So John, I'll send that, because it's not a case of what do I think about that situation. The fact is it's high risk, but more to the point, we do not rely on PPE alone. It's a big fail if all we ever do is put P2 masks on. We are asked to look at administration controls, and that might be about allocation of people per room. But yes, I can tell you that very few people are getting a room on their own when they're admitted to ED. But these portable air cleaners just may be it. So I think I can be useful there. And I know that some of the GPs are thinking, oh, maybe we'll get one of those at our place. But I'm saying, please don't see symptomatic patients inside. And I do know that part of the issue with COVID is, we could say 40% of people who get it don't show symptoms. But I've got to say that half of those, in other words, 20%, are what we call pre-symptomatic, and 20% never get symptoms. Of course, now we've got to throw into the mix those who are immunised and may sort of carry it, begin to get the infection a bit when they're exposed. So I can't account for all that, but I wouldn't race off and spend $800 on a portable air cleaner when I'm doing stupid things like not having the doors open, having 2 receptionists working close together, seeing patients inside unnecessarily. These are all the things the pandemic asked us to look at: administration, handling cash, yuck, handing over receipts, yuck. So no, there's lots of things we can do, but air is huge, huge. Okay, anything else there?
Yeah, we have one more question, which we have a couple of minutes for. It's quite a general question from Jane, but if you could just give us a quick overview, Marg. What masks should we be wearing in general practice?
Okay, general practice, low risk. You're not seeing active cases, I would hope, that you know of. Surgical mask. However, just a little reminder. Hand hygiene, 20 seconds wet contact. You're wanting to disrupt the envelope that the spikes are on so it can't grip your throat. Do it properly. Pop the mask on, bridge nose, of course, at the top. So surgical 3-layer, a third of the way down the nose, press. Make sure it's flat. Do not go like that, because you'll create a little pocket and you'll start breathing through there. Right. When you go to put your glasses on, if your mask is positioned properly, your glasses sit right over there and you don't get any fogging. If I'm seeing patients all during the day, look, you can do that. But that, for inside. But you can basically go like this for a couple of hours. Once this gets wet, when you take this off, only ever take it from the back. Wipe front and back. Obviously, you do your hands. Wipe front and back with 2 separate wipes. That's yours. If anybody's coughed over it, needs to be washed. At the end of the day, wash it, is all I can advise. With this, as soon as it gets wet, it's not working properly. So to take it off, both away and down. Not like this because I'm going to have a cup of tea or a drink. The only place for one of these is the bin when you've finished. There would be no case for receptionists wearing a P2 at this point in time. They shouldn't be in a high risk zone. Their job is absolutely to grill the staff as well as the patients, any symptoms this morning before you came in, don't come in. And that's us as well, okay? We're always cross-checking. Patients, we want you to come, but not inside. We want you to come. We're desperate because we might need to measure their oxygen and next stop hospital. So none of this putting sick patients to the end of the day or COVID patients to the end of the day. You know, they might need some urgent treatment. So we love our patients, we want them. But yes, I might have to hang around in the car park to see a couple of patients, one after the other if I'm in a high-rise building, sorry. But I don't think I want them coming up in the lift, pressing everything and in the lift with two other people, even with masks on. Even with both people wearing masks, you might get 85% protection. We can do better than that. So we're desperate to see our patients, and don't forget the whole point of the immunisation, etc. And what we do is to keep people out of hospital, so we can have people go into hospital for all the other things that they need, like falling off a ladder, because they're all falling off ladders because they're all doing home renos. Okay, so I'm sure you're getting as many calls for suturing and fractures as you are for anything else. Also, I've just been keeping an eye on the level of influenza virus. It's still pretty low. And I think there's some good ads on the telly to say to people, how do you know that your cold is COVID? And that leads me to my final point, is runny nose as a symptom has shot up near the top. Whether this is a slight change with this particular variant, I can't tell you, but headache and runny nose and then, you know, sore throat, only about 40% of people are getting a fever and lower in the elderly, in the more older age group. We will see this happen more in kids simply because the older people are being immunised. But, you know, kids, our childcares have all just closed in Victoria just to try and, you know, jump on this thing. And they're only open for absolutely where both parents are emergency services. So a lot of us have had to do a family bubble, myself included, and you know, it's good that I haven't got the 4-year-old hanging over my shoulder at present. I'll be picking him up later, but that's the decision that we as a family have made with, you know, with that family of 4. They're the only other 4 people we see, so if one of them gets sick, it stops with us. And so that's the, you know, that's the decision, because my son is in emergency services and my daughter-in-law is trying to teach online. So, you know, it's a bit like that. But I did have one PHN, I don't know whether it was yours, where my grandson came in because he can read the clock and he knew that I finished at 4 o'clock, and he came in ringing a bell, which I think to the sort of shock of 150 people on the Zoom. So some of you are nursing a 4-year-old at present. And I think we need to be a little bit more gentle with each other. Sure, it's great to bark orders at everybody like I do, but I think we kind of need to swing with it a bit. And there is only so much you can do. It is going to be very difficult to jump on this thing. And you know what they say? What's the best vaccine for me? The one that's going in my arm today. I think to assure people about the AZ, we've got plenty of AZ. But to assure people that we are so much better at recognising those clots and that we can treat them. And I mean, my own view from just a teensy little bit of reading and a little bit of, you know, positivity is that I wouldn't be surprised if AZ is shown to be, in terms of, you know, memory production, possibly the better vaccine. But that's just me. I'm old-fashioned, okay? All right, so I will send you that paper, Charles, about the air, because I think people will be interested.
Yeah, I'll send that out to everyone. Yeah.
Yeah, so off to work, and as I said, we love our patients, we want to see them, and it might be that you start with telehealth and you go, no, I want you to come in, but how we see them, outside or for the shortest time, inside in an open-doored treatment room, fantastic. Remember, all those managers out there, get all of your doctors and nurses their own personal coffee machine so they can sit in their own offices and enjoy themselves and get a bit of a mental health break, no mask. Because when you're in a room on your own and the windows are open and you've got your coffee machine going, that's sounding a whole lot better to me. And then I can go into the treatment room with the open door to outside and see patients who've got to come inside for examination, but I can go out to cars. We've done the most extraordinary things in people's cars, even do wound changing, you know, wound care. which somebody sort of raised as an op health and safety issue, and I go, who for? But, you know, desperate times, desperate measures, but good medicine will always trump. Yeah. Oh, that's a terrible word to use. We'll always win.
Wonderful. Thank you so much, Marg. We will have to end it there. I know we could keep listening to you all morning, and we appreciate
No, don't. On my website, I've shown you how to put on and take off the full PPE using the P2 mask. So there's an 8-minuter on there on my website.
Great. I'll send the link to your website as well with that article to everyone who's attended today. There was another question, but we'll put that over into the next session. So we are having Marg back again on Thursday, the 2nd of September, same time. So please feel free to join us again for that session. So thank you so much for people for sending in your questions. And of course, thank you, Marg, for being with us. Today is being recorded.
Just lastly, a slight plug. I do a newsletter each month, which is just tips. And I've already just posted my August one, which will go on my website as well. I'll send it to you, and I've got a draft part 2, which is about air cleaners. So it's coming. I've just got to check my 2 references. And so I'll send those to you, Charles, but they'll be on my website tonight.
Okay, great. Thanks, Marg.
See you.
Thanks so much. The session's recorded, so you can watch it again later in our education library, and there will be a short survey that will pop up now when the webinar ends. So thanks again for joining us, and we hope you enjoy the rest of your day.
Thank you very much, everybody.
Thanks, Marg. See ya.
Thanks. See ya.